This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from a 2026 issue of BMJ Open titled Development and Validation of 3 Risk Prediction Models for Clinical Deterioration of Patients After Craniotomy, a retrospective cohort study in China.
This is a topic that hits home for anyone who has spent a night on call. We know that craniotomy is the bread and butter of our field, but it's high stakes. The paper notes that complication rates are significantly higher for craniotomy than for spinal surgery. Specifically, it highlights that the in-hospital mortality rate for patients who suffer an unplanned transfer to the Neurological Intensive Care Unit, the NICU, can be as high as 17%.
Exactly, Dr. Aris. The study defines clinical deterioration as a change from one clinical state to a worse one. The authors argue that patients often show identifiable negative changes in their physiological parameters for several hours before a major adverse event occurs. The challenge, of course, is catching those changes early.
Right. And as it stands, we've been relying on a few traditional tools that have some pretty significant blind spots. They mention the Glasgow Coma Scale, GCS, which we all use, but it doesn't account for vital signs and can't be used in aphasic patients. Then there's the Apache score, which is great for predicting mortality, but less so for the specific deterioration window we need on the ward. And finally, the Early Warning Score, or EWS, which uses vitals but omits things like age and underlying conditions.
That's the gap this study aims to fill. They conducted a retrospective cohort study involving 1,576 patients across 3 large tertiary hospitals in Hunan Province, China, between 2018 and 2020. These were all hospitals directly administered by the National Health Commission, so we're looking at a robust data set.
They didn't just stick to one type of analysis either. They compared 3 different machine learning and statistical methodologies to see which one predicted deterioration best. Ilara, walk us through those models.
They used logistic regression, a Bayes classification model, and a backpropagation neural network, BPNN. They split their 1,576 patients into a training set and a validation set at a 7:3 ratio. They collected a massive amount of demographic and disease-specific data: age, heart rate, systolic blood pressure, respiratory rate, temperature, and level of consciousness.
It's worth noting that they used something called the TOPSIS method, the technique for order preference by similarity to an ideal solution, to evaluate the efficiency of these models. It's a way to rank which model is actually the most ideal for clinical use.
And the results were quite clear. While all 3 models were commendable, the backpropagation neural network, or BPNN, was the clear winner. In both the training and validation sets, it showed the highest efficiency.
Let's look at those numbers, because for our residents listening, these metrics matter. The BPNN model achieved a sensitivity of 77.1% and a specificity of 91.7%. That's a high level of specificity, which means fewer false alarms for the nursing staff.
And the correctness was 86.8%. It also had a positive predictive value, PPV, of 82.3% and a negative predictive value, NPV, of 88.9%. On the other hand, the Bayes classifier actually performed the worst among the 3 evaluated.
That's an important distinction. We often hear machine learning and assume all models are created equal, but this study shows that the architecture of the model, specifically the neural network approach, was superior for the complex, nonlinear variables we see in post-craniotomy patients.
The authors specifically mentioned that this model is intended to serve as a valuable reference for clinical nurses. In many words, identifying deterioration depends heavily on a nurse's individual experience. A junior nurse might see a slight trend in heart rate and respiratory rate differently than a veteran. This model provides an objective technical reference to identify those high-risk patients before they crash.
Let's dive deeper into the strengths of the study. I liked that they used strict diagnostic criteria for deterioration. That minimizes misclassification. If you're building a model on fuzzy data, you get a fuzzy result. By being strict about what constituted a worse clinical state, they enhance the diagnostic accuracy of the tool.
I agree. However, we should also touch on the limitations the authors pointed out. They admitted that they didn't investigate risk factors from the perspective of patient complaints, psychological states, or social support.
That's a fair critique. As surgeons, we know that a patient saying, "I just don't feel right," can sometimes be as predictive as a spike in blood pressure. But for a data-driven model, you need parameters that can be measured consistently. They also didn't look at hospital management factors, which can certainly influence outcomes.
True, but focusing on the physiological parameters, the HR, SBP, RR, and T, gives us something actionable. The paper notes that because craniotomy patients are at such high risk for unplanned NICU transfers, having a tool that specifically accounts for the nuances of neurosurgery rather than just a general surgical tool is a huge step forward.
It really comes down to resource allocation. If the BPNN model tells us a patient is high risk, we can increase the frequency of monitoring or perhaps keep them in a high dependency unit a bit longer. It's about preventing that 17% mortality rate associated with those emergency transfers.
Exactly. And for the medical students listening, it's a great example of how nursing research, which is where this paper originated, intersects with machine learning and neurosurgery. It's a multidisciplinary effort to improve patient safety.
Well said. The study concludes that while they developed 3 models, the backpropagation neural network is the most suitable clinical model to serve as a reliable technical reference. It's a sophisticated way to handle the physiological measurement of patient vital signs and underlying conditions that the EWS often misses.
It's definitely a paper worth reading in full, especially for those interested in risk management and the integration of AI in the neurosurgical ward.
Absolutely. That's all the time we have for today's deep dive. I'm Dr. Aris.
And I'm Dr. Alara.
Thank you for joining us on the Neurosurgery Hub podcast. Keep learning, and we'll see you in the next episode.